Assalamualaikum and a very good morning to all. Let's begin our CME today with Ruqan Al-Fatiha. Before we start our CME today, I would like to remind the participant to turn off your microphone during the talk and don't forget to register in iAttendance for attendance. For medical practitioner, kindly fill in the Google form for CPD point. Google form link will be given in the chat later. Without further ado, I would like to invite Prof. Dr. Ramli Musa from Department of Psychiatry and Mental Health, SASMED, to give his talk titled Current Drug Issue in Malaysia. Please welcome Prof. Ramli.
Okay, Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi washabbihi ajma'in. Allahumma yassir wa la tu'assir wa tammim bil khair bi rahmatika ya arhamar rahimin. Okay, I guess my voice is loud and clear. Can you signal me? Is it clear? Can you respond? Okay. Okay, Alhamdulillah Rabbil Alamin. Okay, this is the first time I conducting the CME for SASMEC. So I guess when I look at the list of participants here, there are a few names that quite familiar, especially from my department, and also a few lecturers lah. Okay, so let me share my screen now. Okay, I hope you can view my screen. I put up in a slideshow. Okay, so today I'm going to deliver this topic, the current drug issue in Malaysia. But let me start off my presentation by showing you this video. Okay, let us view this video, and then you can comment. Boleh nampak tak video ni? Can you hear the sounds?
Yes, nampak Prof.
Okay, good.
Sound tak clear, Prof.
Apa dia? Sound tak clear? Sorry? Did you say sound tak clear?
Gambar nampak, sound tak clear, Prof.
Sound tak clear. Macam mana nak buat sound clear? I've already put up in maximum 100%. Sekejap. Okay, let me louder my volume. Sekarang dengar? Dengar?
Tak clear juga, Prof.
Sorry, apa dia?
Tak clear juga.
Tak clear juga? Ayo, okay, never mind. I think you just not clear at all, ataupun just the volume to very minimal that you can hear.
Very minimal volume.
Very minimal volume. I think I've done my best lah. I put the volume maximum. I think you just observe only lah. Observe boleh. I don't know what else I can do. Okay, you just observe lah. Now he starts showing some signs. Do you notice or not? So actually during the interview, we asked him what kind of substance that he's taking. He said that he do gum. And we asked him, do you have any other substance that you abuse? And then he said yes. So what do you observe? So he seems to be unstable. We asked him to perform some kind of gait, but he has some difficulty. Okay. So this is the first case. This case is actually a case of HTA, and then the one that you saw just now is Dr. Zafri, the previous head of Department of Psychiatry. Okay. So this is the summary of this case. Okay, this case is a 28 years old Malay man, single, working as a laborer, presented with unsteady gait and body tremor. And apart from that, he was referred to psychiatry for some symptom of psychosis. That is second person auditory hallucination for 2 months duration. So that is the reason why he was end up with our department. And looking back at the previous history, he has been abusing glue sniffing for the last 2 years. And not only that, he also at times will take shabu. And because of this psychosis, then we prescribe him on olanzapine. Olanzapine is an antipsychotic. And if let's say you look at the dose, is I think you would notice this low dose of antipsychotic. But once the auditory hallucination has disappeared, we gradually taper off the olanzapine. Okay, so this is the first case. So what's the issue here? Okay, if let's say we can highlight here, as you can observe, patient is having long-standing glue sniffing, and that would cause some kind of neuronal or brain damage. As what you can observe, patient having a jerky movement, unsteady gaze, and there is issue of polysubstance as well as psychosis. Okay, let me show you the next case. Case 2. Again, I'll show you the video, and I guess this is a kind of a sad story in the sense, if let's say you look at the patient. Okay, kat mana sekarang? Hospital mana? Hospital mana? Ini bandar apa ni bandar? So during the interview, I asked his name, and of course we want to assess the orientation. He answered correctly in terms of the place, Bandar Kuantan and so on. So he seems to be quite orientated. He's not confused. So the reason why we ask this question, I think you probably understand that we want to know whether this patient is intoxication or not. Once patient is, if for example a patient is in the state of intoxication, then patient will not be orientated. Adik, dulu ambil apa itu? Kenapa dia ambil gam? ajar. Lepas ni nak ambil lagi tak? Hari ni hari apa? Kalau doktor tanya. Rabu betul? Bulan berapa? 10. Okey. Pergi sekolah lagi tak? Tak lama tak pergi sekolah? Berapa lama tak pergi sekolah? Oh, ya ke? Lepas ni lagi sekolah? Lagi sekolah? Okay. So what do you observe? Since I notice here there are a few. I think I saw Hijaz. Hijaz, do you want to comment anything? What do you observe?
It's like Korea.
Korea only. What else do you notice? What about the orientation? Can you hear the sounds?
In terms of sound, it's not that clear, Prof. But I think in terms of movement, we know that it looks like involuntary movement. Yeah, it looks like Korea, but again, it's as far as I can see that.
Okay. So this is considered as involuntary movement, right? And what else do you notice as now? Do you notice the restraint, the restrainer, but that probably shows that patient was restless in the past. Okay, I want to show back my okay. So this is the case that I saw at the HTA, and the case summaries of this case is so that's why I say that this is a kind of a sad story in the sense that patient is still young, school-going age boy, has been glue sniffing for the past 4 months, and I would say that 4 months is not considered as long term, but that short period caused some kind of neuronal damage. And he's lying on the bed. The reason is he's having unsteady gait, as the same features that you observe from the first case just now, and having the body tremor. And when we ask in terms of the social, the family background, patient actually coming from low socioeconomic family. The mother is a housewife selling kueh, father is a security guard, and he comes from a big family. Okay. So what is the issue here? Although in the literature say that long-term exposure to the glue will cause neuronal damage, but we have seen even a short-term exposure, especially among the young persons. And when we talk about substance problems in Malaysia, they are mostly coming from low socioeconomic family. And why it is so? It is related to the parenting style. It is more, more towards negligent, whereby the parents are busy finding jobs to find the hard-earned money. And so when we talk about substance, do you notice this part, or the slide seems to be actually blocking by this? How to move the thing? Do you see the whole slides or some disturbance on the upper part? Mana satu?
It seems okay, Prof.
Okay, okay. So it's only on my screen only. Okay, when we talk about inhalants, I always remember 5 aspects or 5 points that make the control is so difficult. Okay, number 1, they are targeting vulnerable groups. What does it mean by that? Most of the abuser, they are school going children, whereby I mean, their task is mainly for study, and at this age they are in the development age, so they are vulnerable, and then and it is a very sad that this group were considered as small at the young age. And when we talk about inhalants or glue, especially, it is considered as non-illicit drug. What does it mean by non-illicit drug? It means if someone who is actually possess the glue, we can't actually bring them to the court, because it is the glue is actually is not considered as illicit drug. It is different as compared to those who possess, for example, like heroin. Then we can actually court them. We can catch them. Then we can actually bring them to the court. And the other aspect of glue sniffing is it is easily accessible. They can go to the shop and buy at a very cheap price and then bring home, even at 5 ringgits. Even they can use their pocket money that they're supposed to spend at school, and it is cheap. And when we talk about bring them to the court, it is difficult. Why? Because the process of bring them to the court will require urine test to be positive. So in this case, when we do the urine test, in fact, actually there is no test for urine for the inhalants. So we can't actually do any. I mean, in terms of legal aspect, we can't do anything. And yet the effect of glue is really notorious, very notorious, especially when we talk about the effect to the neuro, to the nerve. And the literature have mentioned here that prolonged or chronic inhalant will cause damage to the neuron. And which part of the neuron will be damaged? It will cause damage in the myelin sheath. So it causes demyelinations to the neuron, especially and eventually it will cause the neurogenic atrophy. And if let's say we look at what actually the substance inside the inhalant that cause nerve damage, and this is what we call the N-axane. N-axane is very notorious. Okay, and not only that, the literature has said that not only it affect on the neuron, but what is the most worried thing is it also affect on the heart, especially the conduction of the heart. And once it is affected, the heart is affected, and it causes the abnormal rhythm, and this is what we observe, what we call the sudden sniffing death syndrome, SSDS. And other adverse effects include seizure, liver damage, kidney damage, choking, and so on. Okay, and okay, now let me bring you to the whole overview of the substance in Malaysia. So we can actually classify this substance into illicit drug, and I like this kind of classification whereby we can talk about illicit drug and then non-illicit drug. Why it is so? Because the way we handle it is different. The illicit drug, usually in the past we will go towards the legal approach, whereas the non-illicit drug is rather really difficult to control it. So what do I mean by illicit drug, which include the cannabis, cocaine, hallucination, the opioids, under the group of opioids, for example, like heroin and so on. But the non-illicit drug is really difficult to control in terms of legal aspect. They include alcohol and also nicotine. Okay. And when we talk about etiology, why the persons engage in substance, we can't run away from the model. This is what we call bio, psycho, social, and spiritual model. So the etiology will follow this model. What does it mean by biological? Okay, biological is include the genetic factor. We found that those it will bring. Those who are actually abusing the drugs, they have the family history of substance as well. So this is what we call the genetic factor, the biological aspect. What about the psychological aspect? Psychological aspect, we found that though The reason why they abuse is mainly among those who are having high stress level, especially like depression and so on. So they would revert to the drug as a form of self-medications. And what about the social aspect? Of course, social aspect also plays a very important role, especially the family aspect, the parenting style, because the social aspect will influence the persons who take the substance, especially the peer influence and so on. And of course, we can't run away from the spiritual aspect because they are lacking in the spiritual aspect. So knowing this etiology is based on bio, psycho, social, and spiritual. So the treatment should follow this model as well. So it's not enough to give medications. We need to pay attention on the social aspect also. Help the family. Correct the parenting style if it is something wrong with the parenting style. Correct the social aspect. And of course the Islamic input as well. So we can't run away from this model. So the drug problem in Malaysia evolved. It is very challenging. Once, for example, like you have resolved A problem, they will evolve to the B problems. Once we have resolved the B problem, they are very creative. They will evolve. They will proceed to the D problems. So it's really difficult to control. Very challenging. But no matter how much challenge that we are faced, we still have to handle this issue. Now, at the individual level, they also evolve. So if let's say we look at the hardcore drug abuser, they start off with the smoking first. Although that's why the reason I would say, although smoking seems to be, some people would look at it's a trivial issues, but you will have to tackle this smoking issue because that is the starting point for them to engage with other substances. So eventually they would go after the smoking, they would go into glue sniffing, and then after that marijuana. Once they have master with this marijuana, they will proceed to the heroin. And even the heroin also, they start off with the snorting first, and eventually they would go to the IV. Intravenous, and that's why they would end up having the HIV. Now, when we talk about the overall drug issue in Malaysia, also they evolve. Last time we heard a lot of issues with the cannabis and heroin, but right now we have partially resolved this issue by having the methadone. But now we have the problem with the new drugs, and this is what we call the designer drug. What do I mean by designer drug is under the category of ATS. ATS is stand for the amphetamine type stimulants. Okay. So now you have to be bear in mind the way we treat drug abuse in Malaysia. We have moving towards the medical model. Last time we look at this problem as social problems. So when we are saying that social problems, the police have to catch them, they have to be penalized, they have to be brought to the courts. So that is more towards the social issue. Whereas now, we want to treat them as an illness, medical illness. So this is what we call medical model. And I think you have heard a lot about decriminalizing approach. So we are moving towards decriminalizing the drug user. Now, you have to bear in mind, it is not, when we are saying decriminalizing, we are not referring to the legalizing. You may probably confused, or you may want to ask the question later on. So, okay, why we are saying that, why we are moving towards medical model? Because we want to treat this problem as medical illness, medical issue, not the social issue. Therefore, once we move toward this direction, it will be less stigma to the sufferer. And then it is less punitive. They will come forward, they have better compliance, eventually they have better outcomes. Now, something very interesting, when you Google in the Google, these terms, this decriminalizing versus legalizing, you will find across this term is very much popular, even to the extent not only just drug, even they are talking about the prostitute as well. And other countries that have been practicing the decriminalizing, for example, like Australia, New Zealand, and Canada. And of course, the main I think you hear about is about the cannabis, the weed. Okay, why we are moving towards medical problems? That is because when you look at the brain itself, can you stop that disturbance? It's coming from home. Okay, when we talk about the why we are moving towards medical model, because when you look at the brain, there is some changes in the brain, especially when we talk about the reward system, which include the nucleus accumbens and so on. This is very much, I mean, the neurotransmitter that plays very important role here is dopamine. Okay, let me bring to you the evidence that I have, which based on my publication, the meta-analysis on the methadone maintenance therapy in Malaysia. So this paper was published 2 years back, or sorry, last year actually, and the paper actually based on all the studies available in Malaysia with regard to the methadone maintenance program. And okay, when we talk about medical assisted therapy, that is the proper terms. Kita tak pakai the words of maintenance or substitution therapy, because substitution means you just give another drugs to cure another drug abuse. So we are talking, the terms appropriate here is a medical assisted therapy. So there are a few drugs that available for the medical assisted therapy, especially, okay, usually if let's say you observe here, the medical assisted therapy, mainly this drug, the treatment is agonist, whereas the non-medical assisted therapies, which include the antagonist, for example, like naloxone and so on. So we have a few, for example, the famous one will be the nicotine, whereby we have nicotine replacement therapy and so on. Now, when we talk about this new designer drug, the ATS, we still actually in the stalemate, in the sense that we do not know what's the best approach. So far, based on a few small clinical trials, bupropion and naltrexone seems to be have some positive results. Now, this paper is we are interested to look at to answer this question. Is MMT, methadone maintenance therapy, would improve the quality of life of our clients? Does it how about the retention rate? Does it if high retention rate means it is quite effective? Does it improve the employment rate of our clients? Does it reduce the criminal rate? Does it reduce the injection frequency? And eventually, does it affect, it has positive effect on the HIV and other risk-taking behaviors? And what about the sexual aspect as well? Does it reduce the sexual exposure and so on? And more important for the policymaker is does MMT is cost effective or not? So to answer all these aspects, we done the meta-analysis. We search all the available publication in Malaysia. In total, there are 16. And I just show you one of the aspect lah. This is the analysis. As I just take one example, this is about the quality of life. So we compare pre and post after the clients in the program, and it shows that it is a significant improvement. Very glaring improvement noted in especially the quality of life. So I don't, okay, when we look at the study, it is seems to be coming from various settings, ADK, universities, prison, and so on. So even one study based on the population in the mosque. Okay, so let me I just skip all this aspect. If let's say you want to know, I can pass you the paper, but I just want to go straight to the conclusion. Conclusion. This is the cost effectiveness, the data that we have. So in conclusion, this study shows that all 8 studies, 8 studies done looking at the quality of life, all are improved in terms of their psychological, social, and well-being, and as well as the physical well-being. It has high retention rate. Some study quoted up to 93%. Okay, some study has shows a better employment rate. It improved the criminal rate, so it is lower the criminal rates, improve the risk-taking behavior, and 4 study shows is quite cost-effective. So, and as you know that the kickstart of the methadone program was in 2005, and has what is observed after that, it shows that HIV also improved. The new cases, last time I think the person in charge at the Putrajaya for HIV, the person is having sleepless nights. Now it seems to be that it is well controlled. So now the HIV, previously it was contributed a lot by the IVDU, but now it's more towards the sex related, especially man to man. Okay, so I just skip this part. Okay, I want to bring you to another dimension. You have to be bear in mind, there are a few substances that caused by the physician itself. So we have to be bear in mind. I've seen a few cases, especially those who are dependent on betadine. It requires IV betadine regularly. I've seen also one person dependent on oxycontin. Oxycontin is one of the opioid as well. Betadine usually come as in the form of IV oxycontin tablets. I have a case whereby very bad dependent on alprazolam. She's coming from KL all the way to Kuantan, and I remember this person had to take the alprazolam. Benzodiazepine is the alprazolam is one of the short-acting benzodiazepine, and then it's very addictive. In fact, in US, it's almost banned, alprazolam, because it's very addictive. So I've seen this case, almost 2 hours she has to take alprazolam. I'm very bad dependent, and the issue here, the person is actually taking it from the GP. So GP has to be responsible as well. But this case seems to be now she's totally resolved. She's now no more dependent on alprazolam, and it was really hard for me to treat the dependent of alprazolam. And currently she's not on alprazolam at all, alhamdulillah. And I've seen also the case of non-benzodiazepine dependent as well. Although if let's say you look at the prescription of zolpidem, it doesn't cause dependent, but bear in mind, I still believe, although it may definitely cause psychological dependent, but not just psychological dependent, also the physical dependent as well, zolpidem. Okay, so this is what happened around the globe. The cause, the clinician cause dependent issues is surging. So we have to bear in mind. We have to be careful when we prescribe the patient on painkiller, especially those who are coming from the opioids groups. I think I stop here. Last time we have this methadone clinic in HTA, and alhamdulillah, based on my study, it shows that our methadone clinic seems to be effective. And it is one of the first publication done coming from the KKM premises. I think I purposely end early of my presentation, so then I can actually entertain more questions if let's say do you have any questions to ask with regard to the substance or substance dependent in Malaysia. Any question? Now, when we talk about clinician-induced substance dependent, I always believe that prevention is better than cure. So you need to be really careful in prescribing the substance, the painkiller, so-called the painkiller coming from the opioids groups, and eventually I would consider that the person will be dumped to us to treat the substance dependence. I mean the opioids dependence, and it is not something. It's a easy job to tackle this. Sometimes they can be manipulative, and we have to use the social skills as well as the clinical skills to tackle these issues. Any questions? Ada soalan tak?
Prof, there is one question in the chat box.
Hold on.
I think from Prof. Nora.
Very.
She said that, thank you for the presentation, excellent. What do you think of the trend of substance abuse in Malaysia now? The reduction of IVDU, but increasing trend of methamphetamine and hallucinogenic.
Okay, I think the question seems to be very general. What is my opinion? Yes, it is a new challenge now. Last time, we managed to partially resolve the issue of methadone. I mean, the issue of heroin. And you know that if let's say you look at the evolutions, if let's say you look at the police statistic, that is not really truly a reflection of what's going on in the public. Because if let's say you look at the police statistic, the main substance abuse in Malaysia was heroin. But in reality, the cannabis is actually number one. But as I told you, when they are in the stage of cannabis abuse, they will not engage in any criminal activities because cannabis is very much psychological dependence. But now moving towards the DSM-5, there is it is considered as physical dependent as well. So when they are at the stage of cannabis, they will not engage in any criminal issues like stealing and so on, robbery. But once they have engaged with heroin, whereby we know that heroin is having short half-life, and the heroin abuse, they will abuse like 3 times a day. And once they couldn't get the supply, they would all do all kind of things to get the substance. Therefore, that is the time that they would engage in the criminal. And now we have resolved the issue. Not to say that totally resolving, but still, when we talk about my study just now, it is cost effective. As you know that methadone is initiated in 2005. So after 1 decade, it is worth to look at the data. Is it worth to proceed with this program? Is the government worth to spend the money for the methadone program? So that is the reason why we conducted that meta-analysis. So in a way, we would want to help the government to make a right decision whether they want to continue with the methadone or not. And So that we have given the answer to them. And yes, now it is a new challenge. When we talk about designer drug, and you have to understand why it is called designer. Actually, you can produce this drug at your home with you can even actually learn in the YouTube. So, okay, that is, then you can create a small lab at your house to produce. But of course, I don't have the skill. It is what based on the experience by the patients. You can actually produce that methamphetamine at your home. And it is a new challenge for us. So at the moment, we do not have any study. I mean, the substitution therapy. Therefore, it is really challenging. So I don't have the answer for that. At the moment, we have a few clinical trials, but still the evidence that we have, it is not promising. Bupropion seems to be effective, yeah, but not very promising. Some study that it is not replicable. So it is remain as at that state. Any other questions?
For participant, we still open the floor if there is any question. Prof, there is one from Dr. Kaylee. Good morning, Prof. What about your encounter with personnel on methamphetamine, known as ketone? Can you share some experience? Thank you.
Okay, I did not mention about the ketone. So it's ketone is very much Malaysians substance, famous substance in Malaysia, especially the Malaysia as well as Thailand. And I mean, we have the controversy in terms of the issue whether we should legalize this ketone or not. Okay, my comment here is, if let's say we want to legalize ketone, it has to be done carefully because we have to understand the pharmacokinetic of ketone, the effect of ketone. The low dose, yes, as you know that ketone is been used for traditionally for certain indications, and for example, like those after the delivery and those who are having menses issues, irregularities in terms of menses and so on. So low dose, yes, it gives the effect of stimulant, low dose. But however, at high dose, it causes similar effect as heroin. So it causes euphoria, it causes impact coordination, impact cognitive function, and so on. So that is the issue. So where to draw the line between low dose and high dose, and how to control the persons from taking high dose. So that is the issue. I have one patient who's actually plant the ketone at his house, and even with one plant, he can actually produce quite a high dose of ketone, and we find it's difficult to control him. So that is my comment on the ketone. I know some clinicians, especially from UMMC, they are moving towards try their best to legalize the ketone. But I still believe it has to be done carefully, because I've seen cases whereby people are dependent on ketone, and it causes the impairment in terms of their life. So, which I not in favor towards that, basically. Okay. Okay, thank you. Any more questions?
I think there's no other question from the audience. Again, thank you, Prof, for your interesting talk. If there's no question, we thank you again, Prof. Ramli Musa, for an interesting talk today. We end our CME today with Tasbih, Kafarah, and Suratul As.
Thank you very much for your attention. Assalamualaikum.